Good morning. We are Team Strive to Thrive. We will introduce ourselves. Our team consists of me, Kevin Pratama Indrajaya, Minsun, and then Surya Damar Putra. We want to bring the topic healthcare system capacity and demand imbalance. Next, please. The healthcare system is under strain. Patient number keep rising, but service capacity is insufficient and unevenly distributed. You can see the patient visit trend from the first chart that show the time range from 2022 to 2025, which shows steady increase of overall patient. But we will focus on the rural patient, the orange line. We will see the first breaking point. In spring 2024, the influx of out-of-town patient, the rural patient, spiked drastically. This was not a random anomaly, as validated by the medical journal in the proof section. A wave of rural Kansas hospitals shut down in late 2023. Our data reveals that the massive delay at SVH, like the 114-day wait in radiology, are not caused by a lack of medication equipment, but a massive administrative bottleneck caused by a surge in local demand instantly followed by the total collapse of Kansas rural healthcare infrastructure. Why did this influx by the SVH system? The bar chart here don't hold the answer. This rural patient did not come to SVH for MRIs, but came purely for basic like X-ray and mammograms, taking up nearly 36% of rural population. However, because SVH lump basic primary imaging and advanced trauma scan into the exact same administrative scheduling queue, the front office was overwhelmed. Our recommendation is SVH must decouple its scheduling queue immediately, but to address the root cause, we examine how patient demand at SVH compared to the surrounding population and what drives this imbalance. To explore the geographic gap and social factor behind it, I'll now hand over it to my colleague.
All right. Thank you, Kevin. So, as we just saw, SVH is bearing the weight of surrounding counties. To understand why, we map the patient to population ratio, which is defined as the number of patients divided by the total population in an area across Northeast Kansas. The data shows a clear imbalance in healthcare access. We can see on the top right, areas without hospitals have much higher patient to population ratio, meaning they have relied heavily on health system departments. In contrast, area with hospitals show lower ratios, indicating reduced healthcare burden. This highlights a structural gap in healthcare distribution. Zooming into the left, we can see that non-hospital cities like Netawaka with 429 ratios, 29% ratios, and Carbondale at 2,090% face extreme healthcare strain. Meanwhile, hospital cities such as Topeka with 9 hospitals and Emporio with 2 act as referral centers, although nearby areas like Meriden still show high demands. Hospital data, it's good to know that hospital data is sourced from the Data Lumos geospatial dataset, while population and socioeconomics variable come from the 2023 American Community Survey. And looking at the bottom right, we can see that correlation results show that healthcare access factors, especially uninsured rate and hospital availability, are the strongest driver of patient burden, followed by transportation access. Overall, the finding highlight that healthcare strain is mainly driven by accessible gaps, not just economic conditions. From here, we will pass the discussion forward to better understand how demand varies in terms of diagnosis patterns and the underlying causes driving these healthcare needs, which will be explained further by Surya. When ready, I will now hand it over to Surya.
Thank you. Now, let's zoom into one specific life cycle factor that drives operational strain, smoking. Smoking is one of the most well-documented drivers of cardiovascular disease, but its operational impact on emergency cares has remained largely invincible until we looked at the numbers. When we break down ED visits by age and smoking status, the pattern is striking. Current smokers aged 18 to 49 visit the ED 3 to 4 times more often than non-smokers. The gap speaks in the 35 until 49 group, where 11% of smokers encounters become emergencies compared to just 3% to never smokers. Even more telling, patients who decline to disclose their smoking status shows ED rates nearly identical to active smokers. That tells us standard screening is missing a hidden at-risk population. And it's not a small group. Kansas BRFSS data confirms smoking prevalence is highest in the same working age brackets. We see overflowing the EDs, 25% at ages 25 until 44 and 17% at 45 until 64. So the populations most likely to smoke are also the ones generating the most acute care demands. When we look at the top diagnosed overall, cardiovascular and respiratory conditions dominate. Exactly the category smoking accelerate. This isn't a coincidence. It's a direct chain from lifestyle to operational burden. The takeaway is simple. Smoking cessation programs aren't just a clinical intervention, they're an operational efficiency strategies. Every former smokers we create is one less recurring ED visitor.
Alright, that's all for us. To conclude, Starman Health is facing a dual challenge. Internally, rising patient demand has created operational bottleneck that require clearer separation between the basic and advanced service queues. Externally, the hospital is absorbing this disproportionate demand from surrounding rural areas due to limited hospital availability and weaker healthcare access. These geographic and social gaps, including uninsured rate, transportation barriers, and lifestyle risks such as smoking, are key drivers to the high patient-to-population burden. Addressing both operational efficiency and upstream accessibility is essential to reducing system strain and improving long-term healthcare outcomes. And that's all for us. In every challenge we found in the data, we choose to strive to thrive. Thank you for listening.